What's up, guys? Dr. Mo here, digital nomad physician at digitalnomadphysician.com. Welcome. February 6th, 2024. I'm still in LA, and got some good stuff for you. Some good stuff to share. So I've been back in the urgent care, as you guys know. Every time I come back to LA, I try to get back into the mix of things, see some patients in person. And there's a couple of locum companies that I work for. There's two of them. And one of them places me in a couple of urgent cares, and the other one mostly puts me in primary care offices. Now, in the past, you guys know, very in the very beginning when I was writing about this stuff, blogging and doing YouTube videos and podcasts, I was very burnt out. I didn't want to see patients in person. I didn't want to have to deal with anybody in person. I was exhausted. And not just like physically exhausted, I was also emotionally, mentally exhausted. I thought like I couldn't do another day of this. And then this is 2016, time passed, and I started realizing that I could actually not see patients and I would be okay. There were other means of income. I had passive income from my investments. I had real estate income. I had my consulting work, and I was selling online courses. And then, physician coaching on my website, everything was making me money. So I knew like, okay, all right, maybe I don't have to work and I don't have to see patients. I don't have to go back into traditional medicine. But I couldn't shake the idea and the feeling that I really liked seeing patients. I really enjoyed being able to do something useful, meaningful for a patient. Not all patients, by the way, but the ones I really liked, or at least the positive experiences. So maybe fast forward a couple more years, and I decided I'm going to get back into it, and I'm going to see some patients, and it was right during the pandemic. So timing was tough because the way patient interactions were back then was, difficult, Anyway, those of you who worked during that time understand what I'm saying. So I took another break. This is, let's say, 2020. And then I took another break, a couple more years, and then I go back into it, and we're pretty much kind of 2022, 2023. I'm like, hey, I feel like I discovered something. I discovered how to show up to work, go to work, see patients, and feel fulfilled without feeling exhausted. And of course, I'd say that this is likely doable because I'm not working full time, but I'm 45 years old. Working full-time, seeing a full schedule of patients, 40, 50 hours a week. I don't know. Number one is for most of us, it shouldn't be necessary if you plan things well, but it's also just not doable. Not doable when you get older. So in this video, I really want to share with you some of the tips and tricks that I used to get myself prepared for my shift, do my shift, come home and feel great. So I earn somewhere around, let's say, $150 an hour. And when I do the urgent care, I usually do a 12-hour shift. And when I do the primary care, I probably do about 8 hours, and I make, let's say, 110, 120, depends. Sometimes. No, at least that much. And in the past, I used to go to the urgent care and I would feel a little bit like a ping pong, or like pinball. I would just, however things happen in the urgent care that day, whatever the pace was, whatever the staffing problems was, I would just roll with the punches. I would say I didn't have the best boundaries, though I consider myself being pretty good with setting boundaries. So now, in the past, I used to just obsess about the next day, anxiety about going into work. I wouldn't plan anything the day before. I would be super cautious about any socialization because I'm a bit of an introvert. And I would just try to conserve all my energy and, be anxious and maybe not even sleep that great the night before. And then go to work. And of course, I just feel exhausted. At the end of the day, I'd just be done. I was a zombie and I couldn't do anything. So it's a little different now. And the way I see my shifts is that I have this process that I go through. So first of all, the day before my shift, I hardly ever think about my shift. It does come up maybe like, oh, it'd be great to have a day off. It'd be great I'll be able to do this tomorrow. I would have loved to go rock climbing. It's little fleeting thoughts. but I don't feel anxiety. I'm still reading my books. The night before, usually the night before of like an anxiety-inducing shift or any shift for me, I would actually not want to do anything that was productive. I didn't want to do anything that was relaxing and mellow. I wanted to do things that completely took my mind off of it, like watch Hoopla, Netflix, YouTube, like dumb YouTube videos. Not dumb, I guess I rarely watch dumb YouTube videos, but something that was very distracting to me. And now I'm just doing my own normal routine. And I wake up in the morning. I usually wake up early. So let's say I have to do an 8 a.m. to 8 p.m. I wake up at 5. For some, that's kind of ridiculous to wake up that early. But I'll tell you what my process is. Number one, I wake up at 5. I want to take a good shit before I go to work. I don't want to feel like I have to use that nasty ass bathroom at work. I want to have my coffee. I want to make my breakfast. I want to read my book. I want to maybe write something on my website. Write something at all. Journal, whatever it is that I want to do. Maybe do some yoga, do some not rock climbing, what is it called? Hangboarding, whatever that I feel like that day. So I wake up at 5 and I'm kind of chill, wake up, it's cold, make my coffee, or, I'm actually trying to coffee-free couple of months. So I'm doing like tea in the morning, and then I'll make a breakfast. And I'm taking my time. There's no rush at all. And maybe an hour before I gotta go, I'll jump in the shower, and then I actually go walk around the block. And the place that I work for, they actually send a car for me. So they do an Uber, so I don't even have to drive. So then I text my office manager, whoever, and she sends a car for me. I get in the car, I'm listening to my podcast, my audiobook. I get to work. Sometimes I take a nap. And that's the beginning of my day. The beauty of it is every time I'm in this Uber, in the morning, the Uber guy is like rushing and trying to get to the place. Like, I'm so sorry, I missed this exit and I'm going here. Because I go to different clinics. And I'm like, I'm not in a rush. Like, I'm getting there early. So I usually leave plenty of time to get there early, to set up, to chill, to fill up my hot tea, set up my station, log in, play my jazz music at work, whatever it is that I want to do. Right? So giving yourself this much time also means when you're on the freeway, you're not rushing, you're not stressed, you're not killing yourself, and you're not going in with that added anxiety into the patient care. And then, now, once I set up, sometimes I work with other clinicians in the office, or there's somebody else in the vicinity where I have my computer and everything set up. So I try to get the formalities out of the way, chat a little bit, and then I try to go into the focus mode. I get on my computer, I set up everything the way I want. Clean up the desk from the previous providers that were there. I mean, not that it's dirty. I just, set it up the way I like it. And then put on my white coat, get my ophthalmoscope, stethoscope, whatever other stuff I need in my pocket, pen. So I'm kind of ready, right? I'm ready. I log in, and when the first patient comes, whether it's primary care or urgent care, I start doing a little bit of a chart biopsy. I don't kill myself, but I want to try to remember their name, their approximate age, and any kind of medication allergies and stuff like that. And that kind of puts me into the zone. So I'm like, all right, I'm going to room 2, gonna go, and what am I gonna ask? Okay, maybe I'll look at some of the stuff the nurses have already done. Maybe they did a urine test or something like that. And I have this agenda in mind. I'm not looking at how many other patients are there. I do some, I'll catch a glance, but I'm not obsessing over it. And I'm also not looking to see, oh my God, there's a laceration coming in, there's an abscess coming in, there's this coming in. That gives me anxiety, and there's nothing I can do about it. So I just look at this one patient, and I go in, I wash my hands, either in the exam room if there's a sink, or outside, and then I just start the conversation. Hi, this is Dr. Ashori. Yeah, tell me what brings you in today, what's going on? And I get the clever answer sometimes, like, you tell me, you're the doctor. Something like somebody might be upset because I'm already late, maybe, right? Like, let's say I'm a few patients in and they've waited an hour, they've waited 2 hours, a little cranky. I come in with my best mood. I come in, hi, I'm Dr. Ashori. I'm so sorry you waited so long. Listen, I'm here for you. Let me sit down. Tell me what's going on. Or en español también. But then I'm just listening. And sometimes I'll catch myself interrupting them, and I just pull back and I say, okay, continue. Anything else? Okay. All right, all right. Now, sometimes they can't see me because in some clinics you have to wear a mask. Most clinics I don't have to. But I try to be courteous. I try to be nice. I try to be friendly. I try to be in a good mood because it actually picks up my mood, which I've really, really enjoyed. And then, so this is my process. It's a whole process. I come in, I get a big history. Now, I might already know that they're COVID positive. I might already know that their urine test is positive. I might already know their pregnancy test is positive, right? I might have some of that stuff already. But I try to leave that towards the part of the section of the soap note, the kind of the objective part, and not bring it up ahead of time. I've noticed that actually messes with my flow. So when I'm talking to the patient, and I'm like, all right, well, yeah, it's really good information. Let me ask you some questions. Okay, what's your past history? Any allergies, any medications? Okay, good. Surgeries if I needed. Why don't we do an examination? Now, sometimes what I do the exam in the chair. And I've noticed that that's not working for me because it doesn't separate things out for me. So I say, all right, why don't you go and hop on the exam table if you're comfortable. Let's do an examination there. That could be a pain in the ass. Some patients are too big to be able to even get on there. Some people have so much pain they can't even move to get up there. But I try to make it happen. And I think you're just going to have to listen to this entire video to understand why. But now I got my HPI, so I got my subjective, and now I got sort of my objective. Now I have in my mind the vitals and everything. Now, unfortunately, I wish I was in the exam room. I could just take another look at the vitals while I'm there because you always forget or mix it up with another patient. But now I'm doing the examination. So I try to say, what is it that I'd want to fill out in this chart when I go back to my computer? What is it that I wish that I knew? Because most of the time when I go and fill out the EHR, I'm like, God damn it, I wish I did this exam. Why didn't I do this? Why didn't I do the neuro on this guy with back pain? What was I thinking? So I try to think of it that way. And now I'm like, oh, okay, so this is what I'm doing. And if I start from head to toe and I say, okay, neuro-optho, ENT and cardiovascular pulmonary, abdominal genitourinary, and muscular and neurovascular, I pretty much covered most of the stuff that I think I want to have before I go create my differential diagnosis and write a complete note. As I'm doing the examination, I talk to the patient. I'm like, oh, okay, let me move you over here a little bit. Or, I'm trying to be courteous. I'm trying to be well-humored. Is that what it's called? Good-humored? And if I do an exam and I feel their lymph nodes and I feel their the thyroid gland and I look in the ears, I always say something. I say, oh, look, you have a lot of scar tissue in your tympanic membrane. Looks like you had a lot of ear infections as a kid. Like, oh, yeah, I did. Or I see scar tissue in the adenoids or tonsils, and I mentioned that. And it's really nice. It connects with the patient, and that's the reason I'm bringing this up as the way I do the process. In the beginning, you're asking a lot of questions, and the patient likes that when you're asking a lot of questions. And when I hear somebody repeating something back and forth to me over and over, yeah, and then my neck started hurting. I'm like, so it sounds like your neck was really hurting. Like, fucking, I heard you, dude. Like, what the fuck, you saying it 1,000 times? But because they don't feel like you heard that part, they'll just keep repeating that. So then I obsess over that a little bit on my end, and then they're like, all right, this guy heard it. I'm done with it. So then when I do the physical exam now, knowing that they know they've told me everything, I'm pretty thorough with the physical examination. Then I say, okay, have a seat. Go back in the chair so that now we can have a discussion. And sometimes I'll say like, hey, look, I need to get a chest x-ray, I need to get a urine test, I need to get this, I need to get that. Or like, oh, this is an abscess, we need to drain it. But I then have that discussion with them, right? This is the part where it's really the assessment and plan. So this really looks to me like gastroenteritis. I've seen a lot of other patients with it right now, kind of diarrhea, nausea, vomiting, fevers, and chills. We can definitely run some other tests if you want. I just don't think it's going to give us much information. The exam was okay. I didn't feel any appendicitis or gallstones or anything. I say the things that I think people are worried about. That's why they're going to an urgent care or they're showing up to their same-day primary care appointment. And then I say, is there anything in particular you're worried about? Is there anything you thought that could be going on? Sometimes I still get the smart-ass answer. You're the doctor. You tell me. Okay, got it. Cute. Yeah, no, I don't think it's anything else. And then they still sometimes say, well, you sure, could it be appendicitis? I'm really worried about that. It's like, motherfucker, I just told you, it ain't shit. So then we say, okay, well, I still would like to get this test done, or I think in this situation, even though I don't think this is what it is, let's go ahead and order an ultrasound. It would be worthwhile to have. I'll send you for that, and the results will come back to me, and we'll have a discussion. So whatever it is, I say, okay, let's do this treatment protocol. Now, let me get to the assessment and plan part, because this is big. This is the part that kills a lot of us, like really fucking burns us out. Classic example, I had a pregnant woman come in, and doesn't matter what trimester she was in, and she had COVID, and she had tested at home, and so she wanted us to test again here. And she's like, well, what do I do? I think I had COVID once before, but I'm really afraid of it, really worried about it. She got some vaccine in the beginning. She never got her boosters or whatever. And she's like, well, I think I want that Paxlovid. And so we had a little bit of a discussion about, pros and cons and some of the data and things like that. And she's like, no, I'm gonna go ahead and want that medicine. So now you find yourself in that situation. Because in the normal situation, like, yeah, it sounds like urinary tract infection. The current recommendation by Infectious Disease Society of America is to start macrobid, nitrofurantoin, or phosphomycin. But if you feel like there's some allergies, or if you've tried other stuff, we could try this, we could try that. By expressing my thought process to the patient and not just, boom, this is what we're gonna do, I feel like I get fewer answers afterwards. And I'll even say, this is the antibiotic. In some people, it causes yeast infection. If you need, diflucan, let me know. If it doesn't get better within 24, 48 hours, you would have to come back and we'd have to maybe do some further testing. Do you have any vaginal discharge if it's a woman, or if it's a guy, like have you been sexually active with a new partner? So I ask some of these questions as I am telling them that this is what I'm gonna do. It's okay, I don't have to do those all in the beginning. I'm not gonna remember to do the whole differential for something. Some things come up, but it's nice because I'm taking the patient through the SOAP note process the way I would in the chart. So a lot of stuff come out. And for those reasons, I rarely think the patient is going to have questions left unanswered. Oftentimes, we'll also talk about, work note. Do you need a work note? What day? That's a nightmare, by the way. I need it to be this from this day, and then when I get back to work, it has to say that I'm not like, fuck, dude. Whatever, I do that too. And then I stand up. And I start walking out. And I say, yeah, can you think of anything else, or anything else I missed that you forgot about? Sometimes, you door handle question that comes up. So as I'm going there, like, all right, the next step is, I'm going to put some things into the computer. I'm going to send your medications to the pharmacy, and I'm going to have the nurse come give you the paperwork, and then you're off. You're good to go. So that's it. Now, this entire process, the way I follow it, makes me feel that I've been thorough, makes me feel that I did everything that I wanted to. I don't end up going home thinking, shoot, I should have done this, I shouldn't have done that, I should have done that, I shouldn't have done this. Or I start writing the note and I'm like, shit, I don't have enough information. A few other things that I try to do as consistently as possible. Again, if there's that argument with a patient, you're gonna have to find your own style, but I'll tell you that I'll make one attempt to tell them what they should do, what's right. I make a second attempt based on what their feedback is. And on the third one, I say, I'm happy to prescribe this for you. You could try to just hold off and see if you get better without it. And if not, you could start it. And that kind of also, I win a little bit of their trust this way, because now they know that I'm not standing in their way. But you might also be the type who's like, nope, never, I would never prescribe this or that or something like that. I have my own things like that, like opioids. I won't prescribe an opioid. I haven't prescribed it in 10 years, not planning on it. And yeah, maybe you're like that with antibiotics. Maybe I'm like that with antibiotics. So I think it's okay to have those very strict boundaries. Like, absolutely not. I'm not giving you a fucking antibiotic for viral pink eye. I'm not going to do it, But then sometimes there's a bit of an argument. Say, yeah, I'm really sorry. I know it's disappointing to not get what you came in here for, but unfortunately, this is the process. And I try to bring it to a close, and I say, you're more than welcome to go see your primary care doctor, or you're more than welcome to get a second opinion from a different clinician somewhere else. But that, that's the I can't budge on that. And that's it. I walk out. That doesn't happen too often. Let's be honest. And we remember it, but it doesn't happen too often. So then I go back. Now, when I write my note, there's so many notes that I've looked back on, and I'm like, they all look the fucking same. All the UTIs look the same. I don't want that. I want them to be a little bit different. So what I do, at least the two sections that I try to put something in, is the HPI and the plan. So in the plan, I'll say, I'll write a little quick differential diagnosis, like could have been pyelonephritis. I don't really think so because of this, this, and this. They were on this, which is why I'm using Cipro. And, or if I'm going to write a medication like that. And then in HBI, I'll say, well, they actually had this, 2 months ago, and now it started. Just by doing a little bit of that, I feel like it grounds me into this chart and makes me not rush off to the next patient either. And then as soon as I set on my computer, by the way, I'm doing the HPI, I'm doing the subjective objective, then the assessment and plan. So I'm ordering the medications, I'm writing the work note, I'm doing all that, and then I click done, sign, and then I tell the nurse, hey, this patient's ready to go. So I don't leave my chart for the next patient. And I think this is a really, really powerful piece for me. And it's been game changing, because in the past I'd say, let me go ahead and leave it so I can rush on to the next patient, which means I also bring all my anxiety into the next patient. And yes, maybe some of you are worried like, oh, but you don't understand. My medical director does this or does that. I don't know what to say. I've been in jobs like that. And the best thing for me was to leave those jobs. So yeah, I hear you. I think this is for somebody who's just looking for a different way to do things, to not feel terribly exhausted. But man, when you do that same routine for every single patient, that systematized process, it's really great. It's a good feeling. And knowing when to pick your battles. If you're exhausted, if you have a ton of patients waiting and all that kind of stuff, how much antibiotic stewardship do you really want to practice? I mean, the patient doesn't care. Medical boards don't really care. Nobody really cares. Let's be honest. Nobody really cares. We care. We care as physicians. Pharmacists care. Sure. Okay. So how much of it do you want? Do you have to be perfect? You could be perfect. Go ahead. That burnt me the fuck out, because back then I realized that nobody else cares about antibiotic stewardship. When I had bad things happen in medicine, from like medical board investigations to whatever, nobody came and said, Dr. Shuri, let's look at your antibiotic stewardship. Fuck no. Nobody gives a shit how shippy you were with antibiotics. So I'm just saying, pick your battles. If this guy comes in here and is like, yeah, I want promethazine with codeine, I look at his chart, I'm like, yeah, this motherfucker's been getting promethazine with codeine. Well, no, promethazine DM, because I don't give codeine. But let's say he comes in for promethazine, and I'm like, all right, he just wants one more time. So I might put up a little bit of a front, bit of a fight, and then say, all right, no, I'm just going to prescribe it. But I might also say, hey, by the way, I know that you have been getting promethazine a lot for your cough. I just wanted to start off by saying that it's just not a medicine that I could prescribe, unfortunately. But with that said, again, the concern of overusing a certain medication, if you're open, I can refer you to this, I can refer you to that, I can do a chest x-ray, I can try a different cough medicine and stuff. So I'm comfortable with that too, like super straight setting the boundary. And you can do that. You're totally in your rights to do that as well, right? So then I go to the next patient. So same process starts all over again. Now, I might get interrupted by a nurse. There's two ways of handling that. I think one of the best ways to handle it, for me usually, is to just say, hey, what's going on? Okay, give me 1 second, and I might finish doing something and say, okay, tell me what's going on. If it's a patient waiting on the line, it's not a big deal. Now, you might be anxious, like, oh, I'm keeping the nurse from checking in the next patient. Why the fuck you're in a rush? That means that if you're gonna do that, you're gonna do it for the whole 12 hours, and you're gonna be perpetually anxious about getting the patient in and not letting anybody wait, which was one of my big flaws. So instead, I'll just go, and if I want to talk to one of the nurses and stand there and just chit-chat a little bit, I'm going to chit-chat. I'm going to take my rest, even if it's in front of the patient waiting room where they can see you. I'm like, I'm not going to not do that, because I don't want to feel that nervous energy. And I've also learned over time that, yes, maybe a clinic tells me, like, you must do this every single time. You must check all the old labs before, end of the day, or you must do this at the beginning of the day, or something along those lines. I've learned that people are a lot more lenient than you think when you say, no, clinic was pretty busy. I was pretty focused on patient care, so I couldn't do that. Sorry. I'll try it again next time. You don't get a lot of pushback. When you stand your ground and you explain things professionally, people will be okay. At the same time, one of the main reasons I created this video is because I work with a lot of other physicians at the same time. They're seeing patients, and they're a hot mess. They're picking fights with the nurse. They're arguing with the patient. They're coming back into the doctor's lounge and they're talking about how bad this patient was, how shitty that patient was, and I can't believe this and I can't believe that. Now, I have those thoughts too. They go through my head. But in a way, for me, my job is to process that information as opposed to express it, once I express it and I make it come to life, it's sort of like this reality that I have to now deal with. When in fact it's not. It's just my impression of this patient. Like even the pregnant patient who was pretty adamant about getting Paxlovid, I was like, yeah, I get it. You know, she didn't trust me as a physician, and she, felt that maybe as a woman and being minority status, she wasn't going to get listened to. She was going to get dismissed. So she really wanted to stand up for herself and get this medicine that she thought was good for her. Fine, good. I just documented it and said, according to up to date, it's appropriate to give it to somebody with pregnancy, even if they're at low risk. And that's it. I just prescribed the medicine. So picking your battles, right? Picking your battles. Anyway, I hope this is helpful. I mean, this should be helpful, because I wish I had something like this. Now, I don't know if I used these tips and tricks back then, it would have been helpful to me, but it is incredibly helpful to me now. I'm going in making $1,600, $1,800 in one day, working, doing something. It's pretty easy for me. So I hope you get to experience the same thing. Take care.